Next, we have Dr. Nuhamin Gebre from Ethiopia, and she's going to share her experience about rural palliative care in Ethiopia. At present, she's doing a PhD in King's College London.
Thank you all. Very happy to be here. I believe it's already afternoon, so good afternoon. I'll raise my voice, I think, as I go along. It's an honor to be here and to speak after very renowned palliative care experts. But I will present from lessons learned in my context, particularly from my PhD. If you're wondering where we are, so Ethiopia is in East Africa, particularly Horn of Africa, and that's in relation to Nepal. So landscape-wise, we have the high mountains, and particularly to indicate the lowest point on Earth is the Dalol, you might know, is in Ethiopia. So to share some demography, we're the second most populous in Africa, and as is being shared here, we have of a large rural population, over 75%. It's been indicated also that palliative care is, as it starts, and also true in our context, is given to particular groups of people, patients with cancer and those living with HIV. You'll see the prevalence here. To say little about our healthcare system, we have three-tier system: the primary care, secondary, and tertiary, and you'll see that the health facilities under each level. And in this slide, I wanted to indicate in the community, particularly in urban and rural context, we have various differences, or healthcare workers who differ in competencies. So in urban centers, we have healthcare workers who are lay community health workers supported by nurses and health officers. But in the urban context, the health extension workers do not have that support. And they are the ones who are often going to homes and stationed at the health post to provide the comprehensive primary care. In terms of policy, in Ethiopia, in 2016, the National Palliative Care Guideline was introduced, and later the Primary Healthcare Guideline endorsed palliative care. You might know the PAC guidelines endorsed palliative care as one of the fields to be incorporated in palliative care, in the primary care. In this recent study, we see the particular challenge with community-based palliative care, particularly lack of or limited healthcare workers trained in palliative care orientation is a challenge. So failure of community health workers to link patients to appropriate care, and also their roles not being defined, so lack of standard of care resulted from this. And in my study, I explored the role of digital health technologies for community-based palliative care. And again, in this recent systematic review from the context, indicated a rising utility of mHealth interventions, particularly mobile applications in the context. But at this stage, it was not incorporated in palliative care approach. But a year, few years after, a team explored the utility of mHealth interventions, again, a mobile app in the community, and the target users in this case were patients and their carers, family carers. And this particular study showed its usefulness in particularly providing information for self-care and symptom management, and healthcare workers also found it to be very accessible and with potential benefits to optimizing resources. So in my study, I explored in these objectives that you see, first, the utility of mHealth interventions from global literature. I used realist review particularly, which explores how they were used and for whom and in what context their utility is very visible. In the local context, we explored contextual utility and potential benefits of such tools, and later used these inputs for a co-design study using a user-centered co-design approach. Some of you might know the MRC, Medical Research Council, guidance for developing complex interventions. So that was embedded in this study to mean we considered context and particular challenge and appropriate resources in the context, as well as developing and refining program theories through the process. I will not go in detail through each phase of the study, but the realist review followed the steps that you'd see here. This is just to highlight the iterative nature and the engagement of stakeholders in the review process. And most of our studies, 93 total, came from high-income countries, and we did not exclude any study designs, but to highlight here that we still need to evaluate such interventions in a rigorous feasibility and trial study designs. So most interventions from global literature showed that mobile apps and mobile phones and tablets were the devices commonly used, and from software you'll see mobile apps and web-based platforms were common. And in terms of how they were used, communication, mainly remote monitoring of symptoms or communication, real-time communication with healthcare providers were the common use. I understand this is a complex diagram, and we're not going to see each contextual factor in detail, but we have mapped our findings to contextual factors that influence the utility of such digital tools to the framework of complexity in palliative care context. And I think from this diagram, we understand that there are complex factors. So in the microsystem, we'll see individuals, both patients, communities, and the healthcare providers are important, and their interaction is depicted in the mesosystem. And we have the exosystem, which is specific to the healthcare system, and macrosystem, which goes beyond healthcare system. So with finance, the social cultural factors all play a role. And in the chronosystem, we have time playing a role. So the dynamic needs and change in preferences of care also play a role in implementing and developing such tools. So with realist review, the context, mechanism, outcome, which are depicted in, again, this complex diagram are one output, but so these are the operational definitions of CMOs in our study. But in this example CMO, I'll try to show you that in the very complex healthcare pathways in which palliative care is like an example. Our interventions need to have such intervention resources to trigger mechanisms. Examples listed here are mainly the strings in relationships or communication that would be enhanced with mHealth interventions to result in clinical individual outcomes or healthcare system level outcomes. Just to mention very briefly, in rural context, we did this qualitative study to see contextual utility of mHealth in the context, and we have patients, family carers, community health workers, and primary care doctors participating. And in the next subsequent quotes, I'll just summarize what was captured. And it was the serious need for information and the need to relieve pain. And if healthcare workers, community health workers, as I described earlier, were trained in palliative care approach, and mHealth was used as a tool to minimize some gaps in skills, knowledge, and communication, it would enhance palliative care access in the community. So we followed with a co-design approach. I will not, again, discuss the details, but we followed a rigorous approach to co-designing the person-based co-design approach was applied. And in the initial workshops, as you see here, we engaged multi-stakeholders to identify the user profiling, the clinical workflow in the communities, what the product requirement for the intervention would be, minimum data sets, and we were able to develop the tool and in a prototype review, capture stakeholders' feedback. So you'll see who was involved in the workshops. Yeah, I think by now you're familiar with the WHO tool, house to indicate palliative care development in countries. We used it to inform some of the discussions and found during the workshop how we can facilitate some of the gaps we identified here. And again, here, the strengths, weaknesses, opportunities, and traits for the end users who are the community health workers in the context was also captured. And in our tool, which I will show very briefly, so we had the patient health records and some of the tools you've been introduced, like the SPICT, the POST tool, were embedded in the mobile application, which facilitated patient health record capture. And although we didn't have an extensive decision support developed, we had embedded clinical protocols and symptom-based alert system in the tool. And there are self-reflection questions and palliative care approach or guidelines to assist the end users. So our app is called Dinkanesh, meaning you're wonderful in our Amharic language. So the end users will log in with their credentials and choose their health facility. The self-reflection questions will also be used to orient them in palliative care approach, and they can see their scores. And the patient health records had the tools that I have described earlier. And these are the selected topics for the palliative care approach to be embedded in the tool. So some implementation considerations for other models of care in the country is the need to have palliative care orientation as a prerequisite before allowing or asking the end users to use the app to implement home-based palliative care, and integration with other healthcare systems, be it the health information system or the routine reporting mechanism in the country, is important. And co-designing and involving multi-sectoral stakeholders was also important, and accessibility, be it language or the e-health literacy, was also important. So we were able to complete stage 2, which was obtaining feedback from the end users, and now we're in a stage where we will pilot the tool in routine care. Thank you very much.
Thank you, Dr. Nuhamin, for giving us a snapshot of Ethiopia and the research work that you're doing. I think in this day of digital era, we have to take advantage of anything we can to improve the care of the people in the rural areas. So thank you so much.